Hi, everyone. You have made it through 9 months of pregnancy in a very short week, and you are now ready for the labor and birthing process. So, what I'd like to do is provide you with a lecture about this process. I know your reading is extremely fascinating this week. I really miss not being able to show you those birthing videos in class and do our activity together, but I'm hoping that this live lecture or recorded live lecture supports you in your understanding of this process. So the first kind of key word I'd like you to know this week is parturition. And this is the name for the process of the cervical and uterine changes that occur when labor is beginning. And so what kind of signals parturition to start? It's actually this corticotropin hormone called CRH. So it says to the placenta, start to release all of the enzymes and all of the changes in the proteins that support the lung development of this baby in utero, because this baby is going to start to come into this real world and need to be able to breathe on its own. So it's really kind of making a signal from one part of the body to another that then tells the woman's body to say, okay, let's start getting ready to push this baby out. So again, the hormones are released. They are brought on by changes in the proteins of the placenta. They tell the woman's body it's time to start to get those muscles ready for contraction and for pushing this baby out. And part of that is making sure that those babies' lungs are ready to breathe real air in the real world outside of the womb. Before actual labor happens, there are some types of contractions that some of you might be familiar with, especially if you've had children in the past, but they're called Braxton Hicks contractions. They're also known as false labor contractions. And they're not for nothing. They're not just to torture women. There's actually a purpose for this false labor. It's still getting the body ready for the real thing. And it's saying, we know that your uterine muscles need to be ready for this extremely difficult labor process. So we're going to start to tone those muscles through the false labor. So there's no cervical changes, but we're toning the muscles in the uterus to support your ability to start to push this baby out. The difference between real labor and false labor, or Braxton Hicks contractions and real labor contractions, is that when you move your position, the contractions will get better. For example, if you go from sitting to standing, if you go take a shower, typically Braxton Hicks contractions will go away. They're also not timed out the same way that real contractions are. And the biggest difference is there's no cervical changes with Braxton Hicks contractions. Whereas in real labor, that's the whole purpose of real labor contractions, is to change the cervix so that the baby can start to come out. Okay. So the stages of childbirth, there are 3 stages of childbirth. That's important to remember. The first stage is dilation of the cervix. This is the longest stage out of the 3. For first-time mothers, this stage is typically between 12 and 16 hours. For all subsequent births, this process can get shorter, but typically first-time births are at least 12 to 16 hours, oftentimes longer, depending on several factors, including the age of the mother, including the size of the mother and the size of the baby. So, and thinking about any complications that might arise during this process as well. So definitely the longest process, the longest stage in this process. You're going to see that these contractions are very regular, and they start to actually increase in not only frequency, but also in how painful they are. So the strength and the frequency increases as you get further along in this first stage, because the cervix is dilating. And this image will never let you look at a grapefruit the same way again, but I just want you to see what 10 centimeters looks like. So between 0 and 4 centimeters, this is typically early labor. Women who are in early labor and call the hospital and say, my contractions are maybe 15 minutes apart. Typically the hospitals will say, walk around a little bit, just rest, don't come in until they're closer to 2 to 3 minutes apart, sometimes 2 to 5 minutes apart. But it's important to get there before 4 centimeters, because typically between 4 and 8, you're going to see some active labor that happens rather quickly. So this early labor typically takes the longest. And then once you're in active labor, that stage typically goes a little bit faster, pending any difficulties or any emergencies that might arise. So then as you, as a woman, are increasing in cervical size to 8 to 10 centimeters, this is called the transition period, because this is typically when that baby is transitioning from the uterus all the way into the cervix, into the birth canal. Okay. I really can't wait for you to watch the balloon video that simulates labor and this stage specifically of labor and childbirth, because it'll show you how the cervix actually shortens and dilates. So you'll see the cervix is typically longer, and what it will do, it is, as the muscles are contracting, the cervix will then shorten and then also be able to widen for that baby to fit through the birth canal. So this stage lasts until the cervix is fully open. So that 12 to 16 hours plus is all about opening the cervix, or dilation of the cervix. The next stage is the descent and emergence of the baby. This should not last more than 2 hours. If it lasts more than 2 hours, typically there is going to be either an emergency C-section, or the doctor is going to require some assistance, such as forceps or a vacuum to assist in the delivery process, which both come with their risks. But when it begins, the baby's head is moving through the cervix and into the birthing canal, and it ends when the baby emerges completely from the mother's body, but is still attached through the umbilical cord. The baby might be, according to its size or according to the mother's physiology, a mother might require what's known as an episiotomy. An episiotomy is a surgical cut from the anus to the vagina, and what it does is it widens that space so that the baby can come out without the mother tearing. And an interesting new finding for research is saying that it's actually safer and the mother heals faster and has a cleaner heel if the mother tears naturally than if the mother were to get a surgical episiotomy. So there's some conflicting data as to what's best practice. So it's always suggested to do your own research and ask lots of questions if you are going to be going through this process at some point. Okay. The very last stage is complete expulsion of the placenta. So mothers think, okay, the baby's out, now I've cut the umbilical cord, I'm done, but you're not. The placenta is what's been keeping this baby alive, and at this time of birth, the placenta is about this big and looks like a big red, meaty, juicy steak, for lack of a better comparison. And so leaving it in the body can actually lead to infection. Leaving any part of it inside the body can lead to infection. So the mother then has to actually deliver the placenta, which almost feels like delivering an entire other baby. So the expulsion of the placenta is the very last stage. Some fun facts about the placenta. Actually, in different cultures, it is either kept and used as fertilizer for a garden. There's a kind of a new popularity of getting the placenta capsulized and put into little pills so that you can take it as a supplement. There's so much iron and there's so many nutrients in the placenta that can support healthy digestion, healthy immune system. So they're actually capsulized for the mother's intake. There's also some other really interesting things that are done with placenta. It's cooked and eaten. I've seen placenta smoothies. It's really interesting what can be done with the placenta. So if you're curious and you're ever in a position where you or someone that you're close enough with that will let you say, hey, want to try my placenta smoothie, then you can have that available to you. I've not been able to engage in that. I didn't know about all this when I gave birth to my daughter, but I think it's pretty fascinating. So I'm curious to see if any of you have tried that. All right, let's look at what happens before the baby is delivered, but while the labor process is starting and is being endured. So there's different types of monitoring to make sure that baby is safe and mom is safe. And what you're going to see is the difference in safety and also the difference in accuracy. When we're using things like external fetal monitors, it's really uncomfortable for the mothers, and it restricts the movement. So moms can't move as much as they might feel like they need to in order to stay comfortable during this very uncomfortable process. But it's not also as accurate, because let's say the mother does move or baby moves, and then all of a sudden the monitors start going off and you hear all this beeping, and what it does is it causes false panic. And so when the doctor comes in, realizes that the monitor has moved, readjust it, and then you have a more accurate reading. There's something that's actually called an internal monitor, and what that does is when the baby's head is down far enough, the doctor or the nurse can actually place the monitor inside of the mother and attach it to the baby internally. So there are risks. Anytime you have a foreign object inside of the mother's body, you are creating a risk for infection. So there is that risk, but the reading is a lot more accurate than the external fetal monitoring. Okay. All right. Here's this debate, and I kind of hate that it's a debate, this vaginal versus cesarean delivery. Cesarean birth is childbirth, and a lot of times there is almost a shame or a critique of mothers who have to get a cesarean section due to some of the challenges with childbirth. And so it's important that we don't minimize that experience of a cesarean birth, because it's actually major surgery and extremely painful and comes with all kinds of psychological and physical impacts as well. We are seeing a lot of cesarean delivery in the United States. In 2008, almost 30% of US births were via cesarean delivery, which is huge. We're among the highest in the world. We have gone down since 2004, but we're still extremely high for our area. There could be reasons for cesarean birth. If the labor progresses too slowly, typically that's a sign that that baby needs some help and might not be moving into the cervix or into the birthing canal and might need to be taken out surgically. If the fetus is in distress, so if those monitors are telling us that this heart rate is too fast or is dropping significantly, that could be a sign of things like the cord wrapped around the baby's neck or around a baby's limb, and that requires an emergency cesarean as well. Another reason is if the mother is bleeding vaginally and bleeding to the point where the doctors aren't able to control it, that could be dangerous for mom's life. Different positions that require a cesarean. If the baby is in a breech position, which means that their feet or their bottom is coming out first, not only is that a very painful way to deliver, but it also is not safe for mother or baby. If the baby is in a transverse position, which means the baby is completely sideways, that is also not an optimal way to deliver. And there's a few things that can happen. Either a baby can go into an emergency cesarean situation, or sometimes doctors ask nurses to do a manual turning of the baby, which is so painful and comes with its own risks and complications. If a baby is too big to pass through the pelvis, if passing through the pelvis is going to either break a mother's pelvis or injure the baby in some way, a cesarean section will also be recommended as well. There are some risks to mothers with a cesarean section: excessive bleeding, infection, different damage to the pelvic organs. Again, this is major surgery, and so the mother is experiencing all of the risks that are associated with a major surgery. Some of the risks to infants: that same hormone that we talked about that clears out the lungs might not be distributed if that mother doesn't start off in vaginal delivery. So they're not going through that labor process and just go in for a cesarean birth without first experiencing labor. Vaginal birth signals oxytocin as well. And so oxytocin is what we call the love hormone or the bonding hormone. And so there's a decrease in that production of oxytocin, but that can be made up for in other ways, such as breastfeeding. A VBAC is a vaginal birth after cesarean. And if a mother would like to have multiple children, when they come back for a birth after they've already had a cesarean delivery, the doctors almost always recommend that all subsequent deliveries are via cesarean as well. If a mother wants a vaginal birth, it's extremely dangerous and not recommended, but depending on several different factors, the doctor might allow it to happen. So, but typically VBACs are discouraged. Okay. Now let's look at another controversial issue: is medicated versus non-medicated delivery. Not all deliveries in all of history had the option of being medicated. It was actually in the 1800s when there was the first medicated delivery. Queen Victoria was the first woman ever in history to be sedated, completely sedated during the delivery of her 8th child. And you think 1800s, what were they using? Typically back then, any kind of sedation was equivalent to something like horse tranquilizer. So I want you to think of that, and also knowing that everything passes through the placenta. That baby also received horse tranquilizer during that medicated childbirth. The alternative is a natural or prepared birth. So what natural prepared childbirth does is it requires families to make a plan. So it says, are you open to medication? If your plan A doesn't work, what's your plan B? What's your plan C? And what it does is it either minimizes the use of drugs or completely eliminates the use of drugs during childbirth. There's other methods as well within that natural prepared childbirth. Lamaze is probably the most common and typically the most frequently offered through the hospital setting. And it requires breathing techniques, concentration on other sensations to ease the perception of pain. So I'll never forget these videos that were made. They're actually audio tapes. That's going to age me a lot. But they're the little cassette tapes, and you'd put the cassette tapes in, and you'd hear this really soothing, almost condescending voice that was saying, listen to the sound of your body, feel the waves, maybe like totally, I mean, when you think hippie childbirth, that's what it felt like. It felt like a meditation spa. It felt like somebody was talking me through this labor process, and what it's meant to do is actually support you in calming your body, calming the pain, reducing pain during the childbirth practice. There's also massage, deep breathing, gentle pushing. And then a very a type of delivery that's gaining popularity is submersion delivery, which is a water birth. So I'm seeing it more frequently, not only in home births, but there's hospital settings that actually have these tubs, bathtubs, where mothers are able to deliver using submersion. Okay. And then with the Bradley method, that is absolutely no medication, and it's completely natural delivery, okay, or non-medicated delivery. All right, what medications are used when medication is chosen or recommended? General anesthesia is rarely used because of the effects it has to both mother and baby. However, local anesthesia is used more frequently, especially when assisted birth is required, such as when a doctor or nurse is having to use forceps or a vacuum. What a pedunal block does is actually numb the area, the vaginal area, so that it's not as painful for the mother to have those forceps being used. An analgesic is just it's a painkiller. So there's so many different types of painkillers that are offered during childbirth, but it's important to remember that anything that is given to mother is passed to the baby during the labor and delivery process. It does have some consequences. It does slow labor down a little bit. It can cause maternal complication and makes baby less alert following the birth. An example of one of the medications, I know something that I took was Demerol. That was very strong, completely knocked me out, but I didn't feel any pain, and it lasted for about 4 hours. And so it does do what it says it's supposed to do if you're interested in medicated childbirth, but it can cause the baby to be a little bit less alert when they're born. 60% of US women actually choose what's known as a regional anesthesia, also known as an epidural or a spinal block. And what that does is actually it's performed by the anesthesiologists who will come in and bring in this giant needle, and while you're in the middle of very painful contractions, tell you don't breathe or move, or you can risk paralysis. So very scary, but it also does its job, but comes with its own set of risks. And a lot of them are migraines for a long time after birth, back pain for a long time after the birth. Paralysis is one that's rare, but can happen. And so you're seeing all of these risks, but at that moment, sometimes it's the only thing that'll get you through that time. So it isn't a choice that's offered to mothers. There's a lot of social and cultural attitudes and customs that play a part of this decision of whether to get medication or whether to not get medication. And what I want to relay is that it's your choice as a mother. It should not be something that you're pressured into doing or pressured into not doing. Every woman knows their own body and their own pain tolerance, and so it's important to do what you think is best for you and your baby. A doula. So doula is also a growing field that research has shown that women who have doulas actually have shorter labors, are less likely to use anesthesia, less likely to have forceps, and fewer cesareans for their birthing process, all because they're having this coach that's supporting them through this process. Okay. All right. And then when this baby is finally emerged in that third stage, you have a newborn baby, also called a neonate. In the first 4 weeks of life, so the first month, that baby is known as a neonate. Typical newborns, the average length is 20 inches and the average weight is 7.5 pounds. For boys, they tend to be a little bit bigger, a little bit longer. Firstborns tend to weigh less than laterborn, so there are some patterns in typical development, but we're talking about averages in this class. For the first few days, it is very likely that children and neonates will lose some weight, typically about 10% of their body weight, which is completely normal, and a lot of it is water weight. But within the first couple weeks, when you bring baby back, they should have gained that weight back plus more. Neonates have an extremely large head. Their head is 1/4 of their body. So I just want you to think about those dimensions for a second. Imagine your head being 1/4 the size of your entire body, which is pretty incredible, which is why babies have such a hard time holding their head up. If you think about it, if you've ever held a baby and seen them kind of do the bobbing on your shoulder, they can't hold their head up because it's just so giant and such a large part of their body. Neonates also tend to have reddish skin. There's also various skin conditions that I'll show you images of in a second. Birthmarks, a receding chin. So that is actually something that it has a role in what babies do right after birth. So that receding chin is actually meant for children to breastfeed more easily, and if you think about it, if they had a more prominent chin, it would be more difficult to latch on. And so that receding chin is actually evolutionary in order to best get that breast milk right after birth. There's also something called the fontanelle, more commonly known as a soft spot on top of the baby's head, and does not fuse until 18 months old because the skeleton is still growing. That skull is still expanding as the brain is growing. So not fused until 18 months old, which means it's still sensitive up to that 18-month-old age. There's something called lanugo. That's this fuzzy prenatal hair on, and it can be all over on the shoulders, on the back, on the face and the forehead. And I'll never forget family just being so surprised and saying, oh my gosh, my baby's so hairy. But typically that's lanugo, and it does go away once the baby matures. And it's very natural for babies to have that lanugo at birth. There's something else that babies are born with called a vernix caseosa, and it's kind of a gross comparison, but it's called the cheesy varnish because of how it looks in the texture, but it has so many nutrients that protect against infection that it's actually recommended that babies are not wiped down or washed off immediately after birth. In fact, you can leave that vernix caseosa on their skin for up to a week and it ends up getting absorbed into the skin, and it's good for protection. There's also something due to the hormones that the mother has passed on to their babies in both boys and girls called witch's milk. And it's when their breasts actually start to lactate. So there's actually milk that comes out due to the amount of estrogen that has been kind of passed into the child through delivery. Females also have a whitish or blood-tinged vaginal discharge. So it almost looks like a small menstrual cycle. I wish somebody would have told me this before I had my baby, because it is scary to see, to change your tiny little neonate's diaper, and to see blood in that diaper was terrifying. But the doctor so kindly explained to me that it was actually because of the estrogen that had been passed down to her during the labor process, that she had this little bit of blood-tinged discharge. So completely normal, does go away once the estrogen is released from their body. So here are some images of some of the conditions that we just talked about. This is that lanugo. Look at that beautiful little fur on these tiny little babies. It does go away. This is the vernix caseosa that, remember, it can be actually absorbed by the skin and is a good immunity and protective layer on that baby's skin. This is something called milia, which is almost like little tiny baby pimples, but is separate separate from baby acne. Each of these goes away on its own. Remember, babies are getting exposed to all these different oils and fingers and kisses and cheeks and all of these different things that are now on their skin that they were never exposed to in utero. So it's very common for babies to kind of break out in those little baby acne or amelia. Please don't use like Clearasil or any kind of acne treatment. This will go away on its own. So no treatment is necessary. All right. Different body systems that neonates are born with. So most babies are born, start to breathe as soon as they're exposed to air, which means that as they're traveling down the birth canal and then they all of a sudden have a blockage of air, this is called anoxia. So a complete lack of oxygen, where they're denied oxygen for an extended period of time. They can also have something called hypoxia, where it's a reduced oxygen supply. So they're still getting some oxygen, just not as much as they need. It is rare, but it can happen due to the repeated compressions of the placenta and the umbilical cord. And if that lack of oxygen lasts longer than 5 minutes, it can cause significant brain damage. Okay. It's also important to see that babies' lungs are functioning at a lot lower capacity than adults' lungs do. They only have 1/10 as many air sacs as we do as adults. And so they're extremely susceptible to respiratory issues. One of those can actually be if a baby has their first bowel movement inside the womb and then breathes in that meconium, it can lead to a lung infection because they're not able to breathe that out. This is meconium. It is the baby's first bowel movement. It is stringy and greenish black. It almost looks like tar. And it is the first bowel movement that's formed within the fetal intestinal tract. There's also a condition known as neonatal jaundice that occurs in almost about 50% of all babies. It's typically caught pretty early, so there's no long-term damage to children. They usually go under phototherapy, which is a light therapy, for maybe a day before they leave the hospital. If it does go undetected, it could lead to more significant brain damage. Okay. So let's look at what are the sensory capacities of these neonates. What can they do? Touch and pain is actually the first sense to develop, and it's the most mature sense in the first few months of life. Newborns do feel pain. They actually feel pain into the third trimester. So before they're even born, they feel pain. So what does that say to procedures like circumcision, where not too long ago, doctors were saying, well, let's get this procedure done early on baby boys because they can't feel it. They can't feel the pain. They'll recover quickly. We know now that they do feel pain, and that significant pain can actually have some serious consequences on babies in the long run. So now when you go into the doctor's office and you've just had a baby boy, you see pamphlets with choices, like here are the benefits to circumcision, here are some information about the cons of circumcision. So some interesting information with the new research. Other sensory capacities is vision. So if you think about it, there's not much to see in the womb. So it's the least developed sense at birth. They're just starting to see, have some stimuli for vision when they are born. Their peripheral vision is very narrow, but it doubles between 2 and 10 weeks. So peripheral vision, if you do this, this is your anything outside of these binoculars is your peripheral vision. So it's that outside vision. And so it's not fully developed at birth and actually develops over time between that 2 and 10 week range. Tracking develops very rapidly in the first few months, and tracking is if you hold an object in front of a baby, the baby will be able to follow it to midline, to the other side, back to midline, to the other side, and so they're learning how to track objects. Typically, it's always the mother's face or a caregiver's face that they're watching from side to side. Color perception develops over the first few months. So initially, babies are seeing in gray tones. They can sometimes see contrasting colors like reds and blacks and whites, but they are not seeing a lot of color, which always cracks me up when these beautiful nurseries are just so colorful and beautiful, and babies come in and they see black and white. And so initially, they're not going to see how beautiful you've decorated a nursery, but over time, they'll be able to see that. Visual acuity is at birth is 2400 and does reach 2020 by 8 months old. I want to recommend for all you iPhone users out there, this app that's called the Babysee. It's Babysyee. It's a free app, and when you download it, you can actually put in a baby's age, like a fictional baby's age, and you can see what they see using your phone camera at that age. So if you made your baby born 2 weeks ago, you can use your camera to see what a baby can see at 2 weeks. If you change the date for 4 months, you can say, this is what the baby can see at 4 months, and see that change. So it's a super cool app. I recommend it if you're interested in it. Binocular vision develops about 4 to 5 months, and that's the ability to use both your eyes simultaneously in unison. Okay? In order to prevent lifelong problems, it's important for early detection to happen. Okay. Now let's look at hearing. Hearing is fascinating to me because it's happening so early in gestation. Babies are listening to what's happening in the world right outside of them. Their mother's voice is the first voice that they remember. They respond to sounds, can recognize sounds, can recognize songs that were played in utero. It's just incredible what babies can identify. And a lot of that I know you discussed in last week's discussion. Early recognition of different voices as well as languages. So babies, when they're born, not only are they able to detect their primary caregiver's voice, but also the primary language, which is so neat to think about. But hearing is key to language development. So if we're not seeing some of those milestones, catching it early can actually prevent some of those later delays in development. Okay. And then smell and taste. Believe it or not, this actually also develops in the womb. The baby is actually taking in smells and tastes through the amniotic fluid. So anything mom eats, the baby is actually getting a sense of those tastes and those smells, and they actually can lead to preferences when the baby is born outside of the womb. And so it's interesting. I hear parents all the time say, I ate a bunch of spicy food and now my baby loves spicy food, or, all I ate was bananas and now my baby loves bananas. And so there's research that supports that taste preference actually starts in utero, which is something to think about, making sure that as a mother, as mothers, that they're taking in a variety of different tastes and textures and smells and all kinds of different things, so that the baby has more exposure to all those different things. Let's see. Through breast milk as well. So not only was taste and smell passed through the amniotic fluid, but then it's also passed through breast milk. So often the breast milk will taste like or have a hint of a certain smell of whatever food you've eaten. A lot of the preferences for young children are evolutionary, so prefer sweet to sour, prefer sweet and don't want bitter. Because what is bitter? Think about what are things that are sour and bitter. Typically they're things that are poison, or things that are not good for you. So our body has gone through this evolutionary stage where we've just discovered that these preferences are to save our lives. Okay. All right. Here are just some different types of assessment. The APGAR score is actually something that is done immediately after birth. It's taken at 1 and 5 minutes, and then a score is given of 0, 1, or 2 at those different times in these different areas. So they're looking at activity, at pulse, at grimace, appearance, and respiration. And depending on those scores actually shows how much intervention is needed during that time to make sure that the baby stays healthy. There's also something called the Brazelton scale that's more of a behavioral assessment. It's looking at how to make sure neonates are responding to stimuli and different types of stimuli. And there's something called the neonatal screening, which is actually a heel prick, and that blood is taken and tested for several different conditions that are important to spot early on, because if not spotted early on, they can lead to later conditions such as death, actually. Okay. Let's look at the activity levels for young children. They do have an internal clock, so neonates are listening to their bodies that regulate their eating, their sleeping, and their elimination. Most babies spend 75% of their time asleep, so what a life, 18 hours a day asleep, because they are going through so many changes cognitively, physically. They need that sleep. They'll typically wake up every 3 to 4 hours to feed. And then you'll see differences between quiet and active sleep. So the difference is in that REM sleep, and that's that deep, deep sleep. Okay. As babies get older and as they recognize light versus dark, they start to sleep later at night and stay awake more during the day. But sleep is also cultural, so it's important to consider what are the family sleeping habits as well, and the baby will typically follow those. Okay. Let's look at low birth weight for a second. So babies who are born preterm, this is any baby that's born before the 37th week of gestation. It is incredible how young a baby can survive. I've actually worked with a set of twins who were born at 25 weeks gestation, which is incredible. And it's miraculously, they're doing amazing and have had a lot of intervention, but are doing incredible. I also have a much younger brother who was adopted, and he was born at 27 weeks, and he was born at just under 2 pounds, which is called a micro preemie. And we were told that he wasn't going to walk, probably wasn't going to talk very much, he was going to be severely cognitively delayed. But he is now 19 years old, taller than I am, skateboards all over the city of Modesto. You've probably seen him, has long blonde hair, and he is very smart, extremely caring, and kind of just said, I'm not going to follow what you said I was going to do. He's able to do so many things, completely typically developing. So I know that's not always the case, but he's a pretty incredible kid. So I'm pretty proud of him. So small for date infants are different than preterm. So small for date, this is a baby who was born at the time they were supposed to be born, but they're smaller than all other babies who were born at that same time. So weighs less than 90% of babies born at the same gestational age. Okay, a lot of this can be due to inadequate prenatal nutrition, but also some of the things that can contribute are things like drug exposure, alcohol exposure, and other teratogens that can cause small for date infants. Prematurity and low birth weight tend to go hand in hand. So if you have a baby born early, typically they're going to be smaller than most babies. And prematurity and low birth weight are actually the second leading causes of death in infancy in the United States, right after birth defects. If you think about it, these babies aren't able to regulate their temperature. They're not able to regulate themselves against infection. They also don't have the lung capacity to breathe on their own. So it's extremely difficult to survive, but with all the medical intervention we have now, we're seeing babies being able not only survive, but to thrive. So in 2004, 8.1% of US babies were born low birth weight, which is considered less than 5.5 pounds. VLBW is very low birth weight, and that is a baby born under 3.5 pounds. So babies born VLBW are more than 100 times more likely to die during their first year because of their lack of body fat and their susceptibility to infection. ELBW is extremely low birth weight, less than 2.5 pounds, very difficult for children who are born this small to survive, but it does happen, as you've heard about my brother. Okay. So treatments and outcomes, again, we talked about the most pressing concern is that immature immune system. They're so vulnerable to infection. They have a very immature nervous system, so they're extremely vulnerable to all the lights and the sounds and all the different sensations. And they have less fat to stay warm. Typically, babies are kept in what's called an isolette, but these isolettes now have options for touch because research has shown that touch actually encourages and supports development in these really small babies. In fact, parents and staff are encouraged to do gentle massage and engage in something called kangaroo care, which is when a parent or a caregiver or anybody literally has that skin-to-skin contact with these young children, they tend to grow faster and do better if they are engaging in that kangaroo care. Okay. So that is my lecture for this week. I hope you enjoyed it. It's such a fascinating time to talk about, and so I always enjoy it. But if you have any questions, please don't hesitate to reach out and ask. Have a good week.